So today we'll be discussing about approach to chest pain and approach to chest pain in view of cardiac chest pain. So we will not be discussing about other pain which are not cardiac or not heart related. So in this approach to chest pain, what we must see, the first and the most important thing which we should do for a chest pain is an ECG. So definitely we need to check the sugar of the patient, blood pressure, heart rate, saturation. These things are must. These must be checked. In fact, vitals are the most important thing. That is heart rate, respiratory rate, BP, saturation, temperature. These things must be seen first. And the second most important thing is doing ECG. So as soon as we do ECG, in ECG we have to see a few things like whether ECG is normal or the ECG is abnormal. So because in approach to chest pain, when means in short we are simply looking for acute coronary syndrome. Acute coronary syndrome, or in short, whether the patient has heart attack or not, whether this is an emergency or not, we are seeing that, and that is acute coronary syndrome, under which three things fall. One is ST elevation MI, second is non-ST elevation MI, and third thing is unstable angina. So these three things fall under acute coronary syndrome. So in here, why ECG is important? Because if there is ST elevation, if the ECG is normal, then it's okay. We have some good time to wait and to evaluate and to repeat ECG. But ECGs, if it is abnormal, then the first thing we need to see is whether there is ST elevation or not. Now, it is very simple. We know that this is an ECG, and this is the baseline. This is the baseline which is in the middle. So we always see presence of ST elevation. So we know that this is a P wave. This is R wave because this is the first positive deflection on the ECG. It is uh, R wave. That is the first positive deflection after P. So first negative deflection after R is S. So this is S, and it should actually touch the baseline. So here it is not touching the baseline. In fact, it is raised from the baseline. This is the baseline. So we can very clearly say that this is S and this is basically a T wave. So this is ST segment and it is elevated. This is the baseline. We can see there is one small box and two small boxes. So there are two small boxes or 2 millimeter elevation. So to call it as MI, to call it as ST elevation MI, we need more than 2 millimeter ST elevation in chest leads. Chest leads means V1 to V6 and or more than 1 millimeter ST elevation in limb leads. So in here 2-3 VF, it is more than 2 millimeter ST elevation means it is ST elevation MI. We can see that lead 2, lead 3 and lead AVF means it is an inferior wall which is supplied by right circumflex artery, sorry, right coronary artery. So this RC is involved, the patient has inferior wall MI. This is an ST elevation MI. So patient has pain, patient has ST elevation. We can label this as ST elevation MI. Nothing more need to be done. We have to treat this as a MI. So whenever it is an MI, what things must be done are the first and the most important thing is patient must be given a loading dose of dual antiplatelet drug, which is ecosprin. Ecosprin is given in 300 milligram dose. Clopidogrel, which is given in 300 milligram dose. Uh, Many of the doctors do prefer ticagrelor or Brilinta in the dose of 180 milligram as well. So this is the dual antiplatelet, either ecosprin or clopidogrel or ecosprin and ticagrelor. Along with that, atorvastatin 80 milligram must be given or rosuvastatin 40 milligram must be given. So this is the loading dose of dual antiplatelet with statins. The second most important thing is given enoxaparin or heparin. So if the patient doesn't have CKD, injection enoxaparin most of the time 0.6 twice a day is given until the patient is discharged, until the patient undergoes angioplasty. Or if it is heparin, then usually as per the dose of the patient, 4,000 to 5,000 unit of heparin is given 4 times a day as a therapeutic dose. So these things are must to be given as soon as this ST elevation MI is labeled. Suppose if the patient doesn't have ST elevation, so we still consider acute coronary syndrome. So then there is a role of the cardiac markers. So in cardiac markers, troponin T, troponin I, or CKMB. These are the three cardiac markers which we can send. So we know the patient had chest pain and ECG showing ST elevation as in this ECG. It means patient has ST elevation MI, means patient has heart attack, means we have to treat the patient. If the patient doesn't have ST elevation, but still pain is there, so if we do ECG, if it is then abnormal, means if the ECG doesn't have any T inversion, ST changes, T changes, then we to call it as MI, to call it as heart attack, we must have two out of the three things. First is patient must have typical symptoms like chest pain, shortness of breath, palpitation, chest heaviness. So pain or pain equivalent has to be there. Second, the ECG changes like ST elevation must be there. If it is not there, then a new onset echo changes has to be there, or the troponin has to be positive. So troponin I or troponin T or CKMB has to be positive. Then we can say that this is not an ST elevation, but this is a non-ST elevation MI. Means heart attack is there, but there is no ST elevation. Because if ST elevation like this is there, then we can directly label it as STEMI. But if ST elevation is not there, but pain is there, and this troponin T, troponin I, or CKMB is positive, means heart attack is there. So these things combined with no ST elevation will fall under non-ST elevation MI. So how to treat? Same. If non-ST elevation MI is there, if we label it as non-ST elevation MI, same. We have to give dual antiplatelet loading dose, that is ecosprin 300, clopidogrel 300, or ticagrelor 180 milligram, and atorvastatin 80 milligram, or rosuvastatin 40 milligram. We have to do this. Again, Clixen also has to be given, or fondaparinux can be given as a 5 milligram OD, or heparin can be given as 5,004 times a day. Then what does change? What is the change in this non-ST elevation and ST elevation? If the treatment is almost same. Uh, Actually, an ST elevation MI, it is an indication for thrombolysis. We can directly thrombolize the patient with tenecteplase or streptokinase or altiplase or eretiplase. We can thrombolize the patient. But if there is non-ST elevation MI, we cannot thrombolize the patient. So to thrombolize, patient must have ST elevation. In non-ST elevation MI, thrombolysis is not actually indicated. But whereas in both the condition, primary angiography and angioplasty can be definitely done. Whether the patient has non-ST elevation MI or ST elevation MI, patient can be directly taken into the cath lab, angiography can be done, and immediately the culprit artery angioplasty can be definitely done. Though the treatment in ST elevation MI and non-ST elevation MI, medicinal treatment remains the same. So there is a third, so this is ST elevation MI, there is non-ST elevation MI. So third thing is unstable angina. So what is unstable angina? So we have seen in unstable angina, definitely there will not be ST elevation. ECG may come normal or it may be abnormal, but the troponin T or troponin I or CKB, it remains normal. So, if troponin T, troponin I, or CKMB, they are normal, and ECG changes are not significant, and if the patient has pain, we'll label it as unstable angina. In some such circumstances, the treatment like dual antiplatelet dose is mostly given, heparin or enoxaparin is given, Clixane is given, but usually emergency angiography and angioplasty is not indicated, though it is advisable to undergo angiography and to see the underlying blockages. But almost it is always never an emergency compared to ST elevation or non-ST elevation MI. For now, this is all, and thank you so much.